Hello and welcome to a lecture in my critical care series. The topic is shock. The objectives for this lecture will be for you to understand the definition of shock, to understand the basic classification of shock subtypes, to apply appropriate initial management to a patient with shock, to understand the principle of volume responsiveness and the techniques that we use to evaluate it, to recognize the standard vasopressors and inotropes that are used in the management of shock and their appropriate use and indications, and along the way to recognize the landmark trials from the critical care literature that have shaped shock management. So to begin with, what is shock? Well, shock is defined as a state characterized by inadequate global tissue perfusion. It is often associated with hypotension, although hypotension by itself is neither necessary nor sufficient to make the diagnosis of shock. That means that we can have hypotensive patients who are not in shock and patients in shock who are not necessarily hypotensive. An example of patients with hypotension that aren't in shock would be patients with markedly low ejection fraction and liver failure. These patients can have low blood pressures without being in shock, as their bodies have been accustomed to low blood pressures and have adapted to it. On the other hand, patients with massive PE or cardiac tamponade can be in shock despite having an apparently normal blood pressure. However, hemodynamically, a drop in the blood pressure is the most significant indicator that the tissues are being underperfused. And so it's important to keep in mind this formula that gives us a relationship between the mean arterial pressure, or MAP, the central venous pressure, or CVP, the cardiac output, and the systemic vascular resistance. So we have that decreases in the mean arterial pressure are either likely due to a decrease in the cardiac output or a decrease in the systemic vascular resistance, which is related to the smooth muscle tone in the arterioles. Now, cardiac output is equal to the heart rate times the stroke volume, and so a drop in the cardiac output can be either due to abnormalities in the heart rate or abnormalities in the stroke volume. And stroke volume itself is related to two major parameters. One is the cardiac preload, and the other is the cardiac contractility. So by understanding these major parameters that affect the perfusion of the body, systemic vascular resistance, heart rate, preload, and contractility, we can now classify shock based on its hemodynamic features. Classically, there are 4 different types of shock that we describe. They are hypovolemic shock, which is characterized by decreased LV preload as a result of low circulating plasma volume. There's cardiogenic shock, where there's a decrease in the left ventricular contractility or heart rate, leading to decreased cardiac output. There is a class called obstructive shock, which is caused by decreased LV preload as a result of impaired right ventricular filling or output. And finally, there's distributive shock subtypes, which are all characterized by a decrease in the systemic vascular resistance. So how do we diagnose a patient with shock? Well, as I mentioned before, hypotension can be a big clue, although by itself it's not necessary or sufficient to make that diagnosis. So we'll need to rely on other clinical findings. And those can include increase in lactic acid levels, which will indicate that the cells are relying more on glycolysis as a result of anaerobic metabolism. Worsening renal function or oliguria, which is suggesting that the kidneys aren't being adequately perfused. Marked increase in liver function tests, particularly the transaminase levels, which can often be in the thousands. This pattern is often referred to as shock liver. Any acute changes in the patient's mental status, which indicates decreased perfusion to the brain. And evidence of decreased perfusion to the heart can manifest as acute heart failure with pulmonary edema, or evidence of cardiac ischemia, which can be through ECG changes or new troponin elevations. Now, all of these features can help us suggest that a patient is actually in shock, but they usually don't help us to define the underlying cause of the patient's shock. So to do that, we need to look at a few other parameters. And those would include the hemodynamic features, such as the patient's central venous pressure, or CVP, which is reflective of the right atrial pressure. The left atrial pressure, historically also known as the pulmonary capillary wedge pressure, which is indicative of left ventricular preload. The cardiac output, which can be measured directly. Related measurement of stroke volume, which is also related to pulse pressure. And the vascular resistances, which include both the systemic vascular resistance, which affects the mean arterial pressure, and the pulmonary circulation resistance, which can be calculated from the mean pulmonary arterial pressure and the cardiac output. So how do we measure these? Well, historically, these measurements were made using a device called a pulmonary arterial catheter, pulmonary artery catheter, or a Swan-Ganz catheter. And this was an invasive procedure which did give all of these parameters that we mentioned before, but could also lead to significant complications as a result of being an invasive procedure. However, they remained in fairly common use until after 2005, when two landmark trials, the Pac-Man trial and the ESCAPE trial, showed that patients who were treated based on a pulmonary artery catheter guided strategy were no better off than patients who were treated without the benefit of a PA catheter. The Pac-Man trial specifically looked at patients with shock, and the ESCAPE trial looked at patients with heart failure. Here is a diagram of how the Swan-Ganz catheter, or PA catheter, works. It's essentially a central catheter that, with multiple ports, it's inserted into the patient's jugular vein and follows the course of the superior vena cava into the patient's right atrium. There it can measure the patient's central venous pressure, and then it continues on through the tricuspid valve into the right ventricle, where it can measure the patient's right ventricular pressures. It continues through the pulmonic valve into the pulmonary artery and measures pressures there. At this point, a balloon at the tip of the catheter is inflated, and the catheter floats along following the course of the patient's blood flow until it gets lodged into one of the distal arterioles in the pulmonary circulation. And at this point, it begins to record the wedge pressure when it gets wedged into the arteriole, and that's reflective of the left atrial pressure. And in this diagram, we see what the pressure tracings at each point in the cardiac chambers would look like. So when the catheter first enters the patient's right atrium, we see a typical right-sided venous tracing, which is reflective of the jugular venous pressures. The average pressure in the right atrium is around 5 in a normal patient, but we see in this case several waves: the A wave, C wave, the X descent, V wave, and Y descent. Once the catheter tip enters the right ventricle, there's a marked difference between systolic and diastolic pressures. This is how you know that you're in the right ventricle. The usual average right ventricular systolic pressure is around 25, and the diastolic pressure is essentially around 0. Once the tip crosses the pulmonic valve and enters the pulmonary artery, we see that the systolic pressure still remains around 25, but the diastolic pressure is higher, around 10. And finally, once the balloon is successfully wedged in place, we see the pulmonary capillary wedge pressure, again reflective of the left atrial pressure. This also has a typical A wave, C wave, X descent, V wave, and Y descent pattern, but the average pressure is much higher than the right atrium, so around 10 rather than around 5 for the right side. In addition to recording pressures, the Swan-Ganz catheter or PA catheter can also measure the cardiac output using a method called thermodilution. We see that the catheter has a port on the proximal end where cold saline can be flushed through. This cold saline will enter the right atrium. And then there is a temperature sensor, thermistor, at the tip of the catheter, which will look for changes in the blood temperature as a result of flushing cold saline here. And the principle is that the higher the cardiac output, the more dilute the cold saline will get. It'll get diluted out with warm blood, and so there'll be less of a change in temperature when measured at the distal port. Whereas if the cardiac output is very low, there'll be less dilution going on, and then the temperature measured at the tip here will drop more significantly. Now, once the Pacman and ESCAPE trials essentially discredited the use of the Swan-Ganz catheter in measuring these parameters, clinicians, especially intensivists, have looked for other less invasive methods to measure all those parameters to get a better idea of what kind of shock the patient has. One of the biggest tools for doing this was the use of bedside ultrasound, which can fairly accurately obtain all of the aforementioned hemodynamic parameters in a completely non-invasive way. So the central venous pressure can be measured or estimated using the patient's inferior vena cava diameter and collapsibility measurements. And it can also be measured more conventionally by hooking a pressure transducer up to a central line. And since most critically ill patients do have central venous catheters in place, it's usually not much of a hassle to get this measurement. The left atrial pressure or pulmonary capillary wedge pressure can be obtained non-invasively using diastolic measurements using ultrasound. This is most commonly achieved using the E to E prime ratio. Cardiac output can be estimated using a variety of techniques. One is the fixed method, which relies on the arterial-venous oxygen saturation difference. Pulse pressure, since pulse pressure is directly correlated to stroke volume. And on ultrasound, using a parameter called the left ventricular outflow tract volume time integral, which we'll discuss later. Finally, we can calculate vascular resistances by determining the mean arterial pressure and dividing by the cardiac output. So once we have some of this hemodynamic information, how can we make use of that to identify what kind of shock our patient has? So if the patient has hypovolemic shock, which can include hypovolemia from acute hemorrhage, adrenal insufficiency, which leads to sodium and fluid loss in the kidneys, or just simply marked intravascular volume depletion. In that case, the patient will have typically low central venous pressure, low stroke volume and cardiac output, low wedge pressure, and a high systemic vascular resistance as a compensatory measure. For these patients, administering IV fluids aggressively is first-line therapy. To estimate the amount of fluids that need to be replaced, We can use clinical features of the patient to estimate the severity of their hypovolemia. That includes looking at their blood pressure, heart rate, respiratory rate, mental status, and urine output. In stage 1 hypovolemic shock, the patient has lost less than 15% of their total blood volume. Stage 1 hypovolemia, rather, they've lost less than 15% of their total blood volume. The blood pressure at this point is normal. Heart rate is usually normal as well. The patient may have slight tachycardia. Respiratory rate is typically less than 20. The mental status is normal, and the urine output is adequate, greater than 30 cc's per hour. Once the patient has lost 15 to 30% of their blood volume, we'll be able to notice orthostatic hypotension, an increase in diastolic blood pressures, increase in the heart rate slightly, slight increase in the respiratory rate, anxiety, and a slight drop in the urine output, around 20 to 30 cc's per hour. From 30 to 40% of total blood loss, the blood pressure, resting blood pressure, the not orthostatic blood pressure actually drops. So the systolic is less than 100, typically greater than 70. Heart rate is even more markedly increased to 120 to 140. Respiratory rate is even more increased. The patient's mental status deteriorates to the point where they're confused, and urine output drops even more significantly. Finally, with more than 40% of blood loss, the systolic blood pressure is less than 70, heart rate is greater than 140, respiratory rate greater than 35. The patient is becoming very poorly responsive and has almost minimal to no urine output. Obstructive shock can be due to conditions such as a tension pneumothorax, cardiac tamponade, a massive pulmonary embolism, and severe asthma. Again, all of these conditions prevent blood from properly crossing from the right ventricle through the pulmonary circulation into the left ventricle, and so the left ventricular preload significantly drops, even though the patient's volume status could be normal. So they're characterized by high central venous pressures with low left atrial pressures, low cardiac output, and again, high systemic vascular resistance as a compensatory mechanism. Let's go through some examples. So tension pneumothorax. On chest x-ray, you'll recognize it by the presence of a completely collapsed lung. As you can see here on the patient's right side, there's absence of lung markings in this area of the lung. The actual lung is collapsed to only cover this space, and the increased pressures from this air have caused a mediastinal shift towards the left, which can compromise hemodynamics. On a bedside ultrasound, this would be identified as through the absence of lung sliding. So normally the pleural line slides back and forth with inspiration and expiration. In a pneumothorax, that sliding is lost. You'll see this difference very prominently in M mode on ultrasound, where in a normal lung you'll see this typical sand on the beach pattern. And in a pneumothorax, where the lung sliding is lost, you'll see a barcode pattern where this pattern of horizontal lines continues downward all the way to the end of the screen. If any of these findings are present in a patient who's hemodynamically unstable, you should treat the patient as having a tension pneumothorax with emergent needle decompression. Cardiac tamponade is typically very easy to identify at the bedside using ultrasound. We look for the presence of a large pericardial effusion with right atrial or right ventricular diastolic collapse and signs of ventricular interdependence. One of the easiest ways of identifying ventricular interdependence is looking for the phenomenon of pulsus paradoxus. And this is a condition that would require emergent pericardiocentesis to restore normal hemodynamic function. Here's an ultrasound image taken from the subcostal window. So it's a subcostal 4-chamber view. Here's the right ventricle. Here's the right ventricle, the right atrium, the left atrium, and the left ventricle. You'll see that around the heart, there's a collection of fluid, and that's the pericardial effusion. Not all pericardial effusions cause tamponade, regardless of how big they are. But the characteristic finding that tells us that this patient likely has tamponade is that the right ventricle appears almost completely collapsed, with almost no lumen in the middle. We also see that the right atrium is also a little bit squished by the presence of this effusion. Although pulmonary emboli are typically definitively diagnosed in most patients through the use of CT angiography or a ventilation perfusion scan, patients in shock are not good candidates to be transported to these kind of tests, and so bedside ultrasound has been used to either diagnose or suggest the diagnosis of a significant pulmonary embolism. The only definitive way to diagnose a pulmonary embolism on ultrasound is to see an actual clot in transit inside the right atrium or right ventricle, passing into the pulmonic valve. Although this is a very rare thing to find in a patient, so instead, most of the time we look for other findings. So patients with particularly high risk for having a PE and who may have either a DVT present on vascular ultrasound or the presence of right heart strain with high risk PE features. Some of the findings of right heart strain on ultrasound would include RV dilatation, the tricuspid annular plane systolic excursion, or TAPSE, less than 17 millimeters, which indicates acute deterioration in the RV systolic function. The D sign, in which the intraventricular septum deviates from the right ventricle inward to the left ventricle during systole. The McConnell sign, which is characterized by impaired contraction of the right ventricular base, but relatively preserved contraction of the right ventricular apex. The 60-60 sign, with a pulmonary acceleration time less than 60 milliseconds, with a pulmonary artery systolic pressure less than 60, typically greater than 30 millimeters of mercury, and IVC distension. When a massive pulmonary embolism is suspected, the patient is typically treated with a 50 milligram IV TPA bolus, followed by another 50 milligrams given over the following hour. Here's an ultrasound of a patient from the apical 4-chamber view. You see the right atrium, right ventricle, and left atrium. And we see an echogenic mass inside the right atrium passing through the tricuspid valve, which is a clot in transit. Cardiogenic shock can be caused by acute decompensated heart failure, an acute myocardial infarction, certain valvular heart diseases such as acute mitral regurgitation or aortic regurgitation, and cardiac arrhythmias. They're all characterized by low cardiac output with a very high left atrial pressure or a wedge pressure. Again, the systemic vascular resistance is usually high as the body is trying to compensate for the low cardiac output. Finally, there's the category of distributive shock. Causes of these include anaphylactic shock, sepsis, adrenal insufficiency, and a set of conditions called neurogenic shock, where the sympathetic nervous system is impaired as a result of spinal cord injury, and this leads to the inability of the blood vessels to vasoconstrict in response to stress. All of these conditions are characterized by low systemic vascular resistance, and the cardiac output can often be increased as a compensatory measure. The only exception might be neurogenic shock, in which the sympathetic nervous system as a whole is impaired, and so the cardiac output is unable to increase in compensation. Here's a summary table of the different kinds of shock and the typical hemodynamic findings you'd expect to see. So again, in hypovolemic shock, low cardiac output, low central venous pressure, low left atrial pressure, with a compensatory high increase in the systemic vascular resistance. In obstructive shock, the cardiac output is again low, but the central venous pressure is high, since blood is having a difficult time crossing from the right ventricle into the left side of the heart. But the left atrial pressures are normal. So that indicates that there's some obstruction between the right side of the heart and the left side of the heart. Cardiogenic shock, very similar to obstructive shock, except the left atrial pressure or wedge pressure is also high. Finally, in distributive shock, this is the only type of shock where the systemic vascular resistance is low and the cardiac output is typically high to compensate. Next, let's discuss initial management and volume responsiveness. So, IV fluids have typically been the mainstay of shock treatment. The theory is that we need to optimize the patient's cardiac preload in order to give them the greatest cardiac output possible for their cardiac condition. We do this by administering intravascular volume, and there have been many discussions over the years as to the best way of replenishing patients' intravascular volume. One of the early trials compared colloid fluids, such as 5% albumin, to crystalloid fluids such as lactated ringers or LR and normal saline. This was a crystal trial published in the New England Journal in 2013, and it showed that for the most part there was no mortality benefit in choosing a colloid solution over a crystalloid solution. However, colloid fluids, since they have the added benefit of pulling volume from the interstitial space into the plasma, would have theoretical benefit in that smaller volumes of fluid can be administered and still have a significant effect on intravascular volume. More recently, a trial was conducted to compare the benefit of balanced crystalloids, such as lactated ringers, that are more reflective of the physiologic electrolyte composition of plasma, compared to normal saline, which has much higher sodium and chloride levels than plasma. This was the SMART trial published in New England Journal in 2018, and it showed that balanced crystalloids were better at preserving patients' renal function and preventing significant metabolic acidosis compared to normal saline. So we know that in general, for most patients, we should choose crystalloids over colloids, and that balanced crystalloids such as LR would be preferable to normal saline. But the next question is, how much fluid do the patients actually need? Because giving them too much fluid can lead to volume overload, which can have its own complications. To understand this, we'll revisit the Frank-Starling Principle. Here's a graph showing how that works. The Frank-Starling law essentially states that over physiologic ranges of left ventricular end diastolic volume, or the left ventricular preload, increases in the preload would also translate into an increase in contractility, which would manifest as increased stroke volume. So essentially, the more you fill the left ventricle just before the start of a contraction, the stronger it will contract during systole. However, the degree of the effect of preload on contractility depends on the strength of the heart at baseline. So these two curves reflect two different hearts. The green curve reflects a heart that has normal systolic function, whereas the blue curve represents a heart that has reduced systolic function. And we see that providing a patient's volume, so bringing them from a preload status of X to a preload status of Y, has a much more significant effect on stroke volume in the normal heart compared to the patient with reduced systolic function. And this is because the patient with the heart having reduced systolic function, their curve plateaus much earlier and has much less of a linear increase portion, which is the preload responsive portion of the curve. So essentially the challenge is, when deciding how much volume we need to give the patient, is to identify on which portion of the curve they're on. If they're on a more linear portion of the curve, then they will be likely to respond to volume. They'll be preload dependent. Whereas if they're on a more plateaued, flat portion of the curve, they're unlikely to have any significant improvement in their hemodynamics after giving volume. So patients who are on this part of the curve, since they're not going to respond to volume, they'll need inotropic agents that are going to increase their contractility, which will shift the curve from this to this, and that will have a much bigger impact on cardiac output than giving them more volume. So what are the tools that we have to assess this? Well, one of the easiest ones is measuring the dynamic behavior of the patient's inferior vena cava, or IVC, as this is a very good surrogate for right ventricular preload. And here's how it's done. This is an ultrasound image taken from a patient's subcostal window, specifically an IVC view. In this view, we see the liver as the most anterior structure, the right atrium as a large dark hypoechoic structure all the way to one side, and a vessel flowing into the right atrium. That's the inferior vena cava. And by measuring the diameter, the maximal diameter of the inferior vena cava, and its respiratory variability, we can get a sense of the patient's volume status. A good way of assessing respiratory variability of the IVC diameter relies on the M mode. So we can map the diameter of the inferior vena cava over time. In a spontaneously breathing patient, inspiration causes negative interthoracic pressure, which pulls blood from the inferior vena cava into the right atrium and causes the IVC to collapse. So this is inspiration. Whereas in expiration, the opposite happens and the IVC dilates. So expiration, inspiration, expiration, and inspiration. By combining the maximal IVC diameter and whether or not 50% or more of the IVC collapses with respiration, we can translate this into an estimate of the right atrial pressure or central venous pressure. And the theory being that patients with low central venous pressures would be more likely to be fluid responsive than patients with high central venous pressures. Now, in spontaneously breathing patients, we can provoke collapse more dramatically by asking the patient to perform an inspiratory sniff. However, there's some pitfalls of using IVC measurements to assess volume status. One common one is that in patients with RV dysfunction, the presence of a distended or non-collapsible IVC should not be taken as a sign of volume overload, because these patients tend to be very volume preload dependent as a result of their RV failure. And so you can often make the situation much worse by trying to diurese a patient with a distended IVC in the presence of significant RV dysfunction. Conversely, in a patient with IVC obstruction due to a compartment syndrome or an intra-abdominal mass, a collapsed IVC should not be interpreted as a sign of intravascular volume depletion. This is because the collapsibility of the IVC in these patients, it has nothing to do with their volume status. It's purely due to the mass effect of the abdomen on the IVC more distally, which is resulting in collapse closer to the heart. A slightly more reliable measure of volume status relies on the concept of stroke volume variability. Since most patients we see that are in shock do require intubation and mechanical ventilation, let's look at the hemodynamics of a patient on a ventilator. So positive pressure ventilation causes a decrease in the RV preload and an increase in the RV afterload during inspiration as a result of the high positive pressure increasing the intrathoracic pressure. On the left side, there's a brief increase in RV preload during early inspiration as the positive pressure essentially helps the blood to get squeezed out from the lungs into the left atrium and increasing the preload. As inspiration continues, essentially the lungs get dried out and the RV preload then starts to fall. This chart summarizes the hemodynamics of positive pressure ventilation. During inspiration, the increase in intrathoracic pressure increases RV afterload, decreases LV preload, whereas it also briefly increases the LV preload. Initially, the decrease in RV preload and increase in RV afterload leads to less blood being able to return to the left atrium over time. Eventually, the pulmonary venous system empties out completely, and the LV preload drops, leading to decrease in the stroke volume. So we see that if we compare the pressure tracing on the ventilator to the arterial pressure as measured from an arterial line, during early inspiration, the arterial pressure slightly increases, then decreases over time. And then once the patient is in expiration, the pressures start to increase again. In a patient who is more likely to be volume responsive, these changes will be much more dramatic, and we can use that to our advantage. One way of doing that is by looking at the patient's arterial tracing, if they have an arterial line. Since pulse pressure is equal to stroke volume over the vascular compliance, respiratory changes in the patient's stroke volume will appear as changes in their pulse amplitude on the arterial line. And we can use a cutoff of greater than 12% stroke volume variability to indicate that a patient is likely to be volume responsive. And possibly the best use of this technique is in a patient who is intubated and not making any spontaneous respiratory efforts, since spontaneous respiratory efforts create negative intrathoracic pressure and interfere with the interpretation. Here's how that would look on a arterial pressure tracing. Again, during inspiration, the increase in the intrathoracic pressure causes a brief increase in the stroke volume and pulse pressure, followed by a gradual decrease. By measuring the maximal pulse pressure and the minimum pulse pressure, and entering it into a formula, we can calculate the stroke volume variability and determine if the patient is likely to be volume responsive using this cutoff. Another useful bedside trick we can use to assess volume responsiveness is the passive leg raise maneuver. This works very well in patients who have both of their legs, who haven't been amputated, since approximately 500 milliliters of venous blood rests in the lower extremities and can be mobilized by raising the legs. Once you do this, all you need is a method of assessing the patient's stroke volume or cardiac output in response to this maneuver, and you'll be able to directly assess whether they're likely to be volume responsive. This is a diagram of how this maneuver is essentially carried out. You start with a patient with their torso at 45 degrees and their legs horizontal, and you can measure their cardiac output using ultrasound in this position. Afterwards, you reposition them so that their torso is flat and their legs are raised up at 45 degrees, and then you'll reassess their cardiac output in this position. One of the best ways of using ultrasound to assess a patient's cardiac output relies on a parameter called the left ventricular outflow tract volume time integral, or VTI. So stroke volume can be given directly by the formula stroke volume equals pi times the left ventricular outflow tract radius squared, or left ventricular outflow tract diameter over 2 squared, times the left ventricular outflow tract volume time integral. And since the cardiac output is equal to the stroke volume times the heart rate, we can multiply this value by the heart rate to get the cardiac output, and then divide by the patient's body surface area to get their cardiac index. In order to measure this left ventricular outflow tract volume time integral, we'd have to obtain this view, which is an apical 5-chamber view, the 5th chamber being the left ventricular outflow tract here. Using pulse wave Doppler positioned right at the aortic valve, we can measure the velocity of blood flowing outward through the aortic valve over time, and that'll give us a graph like this. And the area under this curve is equal to the left ventricular outflow tract volume time integral. Then once we measure the diameter of the left ventricular outflow tract, typically this is done in the parasternal long axis view, we can enter that into the equation, and once there we can calculate the stroke volume, cardiac output, and cardiac index. Another important clinical decision-making strategy relies on the patient's central venous oxygen saturation to assess their cardiac output status. This is based on the Fick equation, which relates oxygen extraction to cardiac output. So the cardiac output is given by the oxygen utilization divided by the arteriovenous oxygen difference, or the oxygen extraction. Essentially, this equation is telling us that in low cardiac output states, more oxygen is extracted from the arterial blood, and so the central venous oxygen will be low. This is because the blood is flowing more slowly and has more time for the tissues to extract blood from that. Conversely, in high output states, such as sepsis, less oxygen is extracted from the arterial blood, and so the central venous oxygen saturation will be high. Central venous oxygen saturation is typically measured by drawing a venous blood gas from a central venous catheter. Finally, let's discuss the medical therapy that we use to treat patients with shock. Once we've optimized a patient's volume status and the patient is still having signs of inadequate tissue perfusion, the next line are drugs that will raise the patient's blood pressure. These include the vasopressors and inotropes. Vasopressors are essentially any class of drugs that will increase a patient's vascular tone or systemic vascular resistance to increase their blood pressure, whereas inotropes focus more on increasing the patient's cardiac contractility, which affects their cardiac output. Importantly, the stronger the vasoconstrictive properties of a drug, typically the worse the effect of that drug on the patient's cardiac output. This is largely due to the increase in left ventricular afterload that's caused by increased systemic vascular resistance. Conversely, drugs that tend to be strong inotropes and increase the contractility of the heart also cause vasodilation. So essentially, with vasopressors and inotropes, there's a trade-off between increasing the SVR and increasing the cardiac output. With that said, let's look at the common medications that are used. First, there's vasopressin, which is a very strong isolated vasoconstrictor, so vasopressor, which acts only on the systemic vascular resistance with a negative inotropic effect on the heart. It directly acts on V1A receptors and causes vasoconstriction of the vascular smooth muscle. It's typically administered in a fixed dose of 0.04 units per minute and is often helpful in patients with GI bleeding that are related to shock, as it can cause vasoconstriction, particularly of the mesenteric vessels. And it's often a useful adjunct in patients with septic shock, next to norepinephrine. Phenylephrine is a pure alpha-1 agonist. It's titrated in a dose range of 100 to 500 micrograms per minute. It's fallen out of favor as a first-line agent in septic shock and many other types of shock, although it still retains an important niche role in shock that's associated with tachyarrhythmias, shock that's associated with high cardiac output states, and shock that's associated with LV outflow tract obstruction, such as patients with hypertrophic obstructive cardiomyopathy. It's known to be associated with a reflex bradycardia. Norepinephrine is a combined alpha-1 and beta-1 agonist, although the alpha-1 activity is much stronger than the beta-1 activity. It's titrated starting from a dose of 5 micrograms per minute and as high as 125 micrograms per minute or more. It's become the first-line agent in both septic and cardiogenic shock with no other contraindications for its use, but is associated with causing tachyarrhythmias. And in those cases, it may be more beneficial to switch to phenylephrine. Epinephrine acts on all of the peripheral sympathetic receptors, alpha-1, beta-1, and beta-2. It has a dose-dependent effect in where lower doses from 2 to 10 micrograms per minute act only on the beta receptors and have more of an inotropic effect, whereas higher doses, 10 to 30 micrograms per minute, have a much stronger alpha-1 effect. It's a useful adjunct agent in both septic and cardiogenic shock, but has an important first-line role in anaphylactic shock, since the beta-2 effect helps to reverse bronchospasm. One of the notable side effects of administering epinephrine is the presence of a type B lactic acidosis as a result of epinephrine's effects on glycolysis. And it's important to recognize this because an increase in lactic acid levels after administration of epinephrine shouldn't be taken as a sign that shock is getting worse on its own. Dopamine is, although previously commonly used in different types of shock, has increasingly fallen out of favor. It acts mostly on the D1 receptor. Similar to epinephrine, it has dose-dependent effects. In the past, many clinicians focused on the very low dose dopamine, as it was thought to have a protective effect in preserving renal and mesenteric blood flow, although this has become much more controversial and most clinicians don't use it for this purpose anymore. Higher doses are similar to epinephrine, where the medium dose has a predominantly beta-1 type effect on increasing inotropy, and higher doses still 10 to 20 micrograms per kilogram per minute act both on similar to high-dose epinephrine. It does have a limited role in the modern clinical practice for patients with bradycardic shock. Next, there are the inotropes, the pure inotropes, dobutamine and milrinone. Dobutamine is a beta-1 and beta-2 agonist. The beta-1 activity is slightly stronger. It does not have any alpha-1 activity, and it's used predominantly as an adjunct in cardiogenic shock, particularly in patients with RV failure. Milrinone is a phosphodiesterase 3 receptor agonist. It acts by increasing cyclic AMP levels and in turn increasing calcium levels in the heart, which increases contractility. And again, this is an adjunct agent used in cardiogenic shock. So which drug should I use to treat a patient with shock? As expected, hypovolemic shock is almost always treated with fluids alone, with no need for adjunct pressor agents. When it comes to cardiogenic shock, many clinicians for a long time believed that stronger inotrope agents would be better at improving outcomes in patients with cardiogenic shock, since it directly improved or acted on cardiac output. However, a landmark trial published in New England Journal in 2010 called the SOAP-2 trial showed that dopamine, despite theoretically being a stronger inotrope than norepinephrine, did worse in cardiogenic shock compared to norepinephrine. And as a result of this trial, norepinephrine suddenly became the first-line agent in cardiogenic shock, as well as septic shock. And it's continued to hold this role even today. As I mentioned before, phenylephrine is also considered a more inferior agent to norepinephrine in most kinds of shock, although it continues to have a role in treating shock associated with refractory tachyarrhythmias, LVOT obstruction, and where cardiac output appears to be well preserved. Septic shock turns out to be one of the more complicated forms of shock in terms of treatment, since its hemodynamic characteristics can be different from patient to patient and different over time in the same patient. Traditionally, early sepsis will present as a high cardiac output state with an isolated decrease in the systemic vascular resistance. And so in these patients, the heart is typically hyperdynamic, and so the very little inotropic effect is needed to improve the patient's blood pressure. Instead, you're going to rely more on pure vasopressors to increase their systemic vascular resistance. However, many patients with septic shock who previously had very healthy hearts can develop something called septic cardiomyopathy as a result of the infection. This is where the sepsis itself has a negative effect on the patient's cardiac function, leading to decreased ejection fraction and low cardiac output. These patients can be easily identified by a decrease in their SCVO2 and low cardiac output on ultrasound assessment. And so for these patients, adjunctive agents that have inotropic effect would be more beneficial. In practice, both of these patients would be given norepinephrine as the first-line agent, but the patient with relatively preserved cardiac output might benefit most from a drug such as vasopressin as the second-line agent, whereas the patient with marked septic cardiomyopathy would probably benefit more from epinephrine as a second-line agent. Finally, in patients with refractory septic shock who require 2 or more pressors, it's common practice to add steroids, specifically the hydrocortisone, given as IV push 50 milligrams Q6 hours. This has been shown to hasten the recovery from shock, although it does not appear to have any mortality benefit. And this was studied in the Corticus trial published in New England Journal of Medicine in 2008. And that concludes my lecture on shock. Hope that was very helpful for you, and have a wonderful day.